I think most of the folks on stage need no introduction, but let's quickly go and tell each other who you are. I've been talking to these guys for 3 days now. Chris, why don't you start?
So I'm Chris Wickley. Hello? Look at that. This level of technology is beyond me. Hi, I'm Chris Wickley. I'm the Chief Executive at Genomics England.
Heidi Ream, I'm the Chief Genomics Officer at Mass General Hospital and the co-director of the Medical and Population Genetics Program at the Broad Institute.
I am Diana
Yep.
That's on. Yeah. I'm Diana Bianchi. I'm a geneticist and a neonatologist, and I'm currently the director of the National Institute of Child Health and Human Development, which has funded over 1,350 research grants related to newborn screening.
Wow. Okay. Well, first of all, Diana, since you're the ranking NIH representative here, thank you. Thank you for all of that. Thank you for the insight, your contributions to the Insight program, and thank you for being here today. We've talked a lot. We've had about 8 pilot programs from around the world talking here, and they all depend on outside funding. What I'd like to ask each of you, and we'll come back at the end to sort of your comments on the, well, actually, let's start with that. Diana, you've been here for a day or two. Before we jump into my questions, I think you had some things you wanted to comment on from the previous sessions, and let me let you get that off your chest.
Oh, thank you, Robert. No, I'm here today listening, fly on the back wall there. And one of the things I did notice, and I'm not sure if Dr. Cunningham is still there yet, he's still here. I really resonated with your comments. I think that one of our biggest efforts needs to be diversifying the workforce. I believe that there are only 10 African American medical geneticists, for example. I've mentored 2 of them. There is now a support group for 10 of them, but we're really not going to go very far if we only have 10 medical geneticists, and I'm not even sure how many African American genetic counselors we have, but 14? 46, okay, easy to remember, number of chromosomes, right? We need to do more. And we've had a number of other successful programs bringing in underrepresented members of minority groups into various projects. I can say that we have a big project right now on Down syndrome, and we ran a summer program that brought in college students actually to teach them about sequencing and how they can apply their knowledge to research in Down syndrome. Why don't we do that for newborn screening? I think that we either have to start there or we have to start in high school, actually. And there are a number of high school internships, for example, where kids can come to the NIH. You're from Washington, you may have been familiar with them. They come in, they spend the summer at NIH, they're exposed to research. Why don't we create a program that concentrates on diversifying the pool of investigators who will be the future of newborn screening?
So I agree completely, and that needs to be done, I think, can be done at every level, the lab level, the healthcare institution level, regional levels. At our tiny Genomes to People program and PPH with Ariadne, we managed to get donor funding to bring in 3 to 5 students of color every summer who are paid a stipend to come and learn with us for the summer, and most of them coming from Howard University, where we have that relationship. Let me,
sorry, can I jump in?
Sure.
Just in the spirit of the conversation we just had about sharing international learnings. I mean, in England and the UK, we've set up a thing called 10,000 Black interns across health data science and genomics. At Genomics England, we're taking a number of interns every summer and so on. So I think for us, setting that level of ambition of like some big numbers and then holding ourselves to account to kind of hit those big numbers has been just a simple but kind of good energizing move, I think, for the community.
So I got a couple of questions that I really think these folks will have particular insights on. So there are about 8 pilot programs that presented themselves in detail today, and they were not all, but almost all of the programs around the world that are doing or about to do newborn sequencing. all are sort of depending on outside or unique funding sources. And the UK may be special, but I would like to get your thoughts on how does this go from being pilot studies with unique sources of funding to sustainable programs, assuming we demonstrate the value we think it's going to demonstrate.
Do you want me to?
Sure, you want to kick off?
Sure.
You might have the easiest answer.
No, I mean, the funding question is a really interesting one. We are being funded by central government to do this program. It's not coming out of regular NHS funding. It's a separate sort of special initiative. We were delighted, and we were also surprised when we got the funding for it. And sometimes, you know, the Lord and governmental funding programs move in mysterious ways, right? So we got about 12 hours notice before the Chancellor stood up in Parliament and said, we're doing this. So can you give some lines and can you do a press notice, please? So we were simultaneously kind of like, wow, we should celebrate this, and frantically typing out press notices and things. We felt it was important that the core funding came from government, not from the private sector, for reasons of trust and transparency about what would happen with the data and so on. We collaborate with the private sector in lots of different ways at Genomics England, and the way that we've managed to do that while sustaining transparency and trust is by putting participants in charge of the choice of who gets access to their data, what kind of partnerships we do. And we think, you know, we would use those same mechanisms in this context because they've been proven to work. And I think that's really important for the second of our aims. So the first aim is screening at birth. The second aim is new therapeutics for babies. The third is kind of life course follow-up. New therapeutics come through collaborations with the private sector. They don't come through collaborations with academia.
Heidi, you wear many hats, but one of them has been trying to get things going at Mass General Brigham program with insurance coverage. And as you look at the landscape, any thoughts on this?
Yeah, I mean, from my perspective, I actually think it's a little bit of a hard argument right now to say we should sequence every newborn born and fund it. I actually think it's a really hard argument. Where I think there is a really strong argument is in diagnostics. We can't even get coverage for a lot of basic genetic testing for individuals with symptoms. But there's an increasing number of avenues where it's very clear that genetics are very useful and are starting to be covered, and they include expanded carrier screening in reproductive stage, increasing use of pharmacogenomics, diagnostic testing for rare disease, and the list goes on. And you can easily, you know, add up all of those things and say, well, they're all higher yield with a genome. So at what point do we just say this is more useful if we just run a genome on everyone, and then we can use it for all of these different questions? And if you look at the actual prevalence of rare diseases and add them all up, you're talking about close to 1 in 10 individuals. So you start to get to an economics argument that really we should sequence every baby at birth and have their genome for life and ask all these questions. The challenge is that the infrastructure and scalability isn't there yet, and we are constantly innovating at every step of the way. You know, new announcements on new technologies for sequencing just happening, you know, so that the sequence data is going to change, and the genome we generate today is honestly not the one we're going to use, certainly in 10 years, but probably not next year or in 5 years. The intensity of the work involved in interpretation is still very high, and there's a lot of infrastructure we need to build to make that scalable and cheaper. Because to really interpret a genome at birth right now, the economics in terms of the amount of work that is a little hard to argue. You know, maybe if you're incredibly focused with what you're interpreting, you know, you could make an argument that with that level of focus, you could do it okay, but it's still a hard argument with the infrastructure we have to support interpretation. So I think, you know, there's a hard argument to make right now. However, we're never going to get there if we don't start piloting these projects and start, you know, it's like a whack-a-mole. Like you start hitting each of the areas you need to innovate in, and you can't do that overnight. You have to build towards it. So in my mind, we do have to start now. And we're going to have to fund it in innovative ways. It's not going to be making an argument to insurance in the US that they're going to cover this. Not going to happen. But we do have to cover it because there's so many questions we need to answer and so much infrastructure we need to build that we have to start now, is sort of my argument.
So I would like to give a sort of a positive interpretation. You're not going to see change overnight, but we've seen incredible progress. I mean, my particular research, and I'm still an active researcher in prenatal screening for aneuploidy and for other genetic disorders. And, you know, in a period of 10 years, remember in 2011, that was the first time you could get non-invasive prenatal testing using cell-free DNA. And at the time, you had to pay a lot for that. In 10 years, it's virtually covered for high-risk women in both public and private settings. And now the state of California is offering it as its first tier genetic screen. So that's 10 years. You saw Stephen Kingsmore showed you that 6 states are covering sequencing for critically ill newborns. That's incremental progress. I mean, I think what you'll see is more and more states will begin to cover it for, and private insurers hopefully will cover it for critically ill newborns who are the plan busters. I'm a neonatologist. These babies, especially the term babies where you don't know what's wrong with them, but you know that they're sick, they stay an incredibly long amount of time in the NICU. So it's a money saving, never mind all the other many, many benefits. So I think that's gonna all happen to be followed by healthy newborns. Once you have data both on, what are the benefits, which BabySeq has shown, but you need to do that on a larger scale. You need to do it internationally. You need to do it with a wide variety of populations.
Fantastic. The next question is about private industry and its relationship. 2 of us on the stage here are academics, 2 of you work for governments. But we've had at this meeting, I'm very proud that we've had a good representation of industry players, not comprehensive by any means, but who are interested in moving this area forward, disrupting this area, propelling this area, enthusiastically doing so out of the best of motives, but also as private industry. We have traditionally had divisions between academia and industry that have sometimes been hard to cross. In this field, I think we've already talked at this meeting about how we're working more and more together. Where do you see we should continue to work closely together? Where, if anywhere, should we be more cautious about the possibly conflicting agendas that we have in these, well, let's say government policy, academia, and industry?
Yeah, I mean, we work very closely with industry. They play a huge role in the genetic testing arena, and share data in ClinVar. The vast majority of laboratories, in fact, most of the data in ClinVar is from commercial laboratories. And so they're a necessary and important and major contributor to the entire industry. And I think, in order to bring the cost down, you either need to have, scalable commercial solutions, or you need to get academia and the global community to come together in ways that I think we haven't always done a good job, with individual academic medical centers and healthcare systems actually partnering in ways that they can also achieve the same scale. So I think we have to achieve the scale in order to bring the cost down, and we have to be innovative. And if commercial industry is the way to do that, then that's a solution. There's other ways that we can gain economies of scale as well.
Go ahead.
I guess for me, it's about breaking down the different bits of what we're talking about, right? So, I mean, I'm flanked by an Illumina pillar and an Oxford Nanopore pillar, right? We're not about to start a kind of state-owned sequencing machinery company in the UK, right? So, and I don't think anyone has any qualms with, like, of course, we partner with the private sector to do sequencing, right? Likewise, I think on a lot of the systems, there were hesitations maybe 10 years ago about storing this kind of data in the cloud. I think those have gone. We realize this is a better, more scalable, more secure, better for the patients and research participants whose data it is. Fine. I think the question of these collaborations around therapeutics, again, we know that the only place therapeutics come from is partnerships with pharma companies. I think the question of access to and ownership of data is one of the ones that's most central. In the UK, one of the big concerns is, and it must be even more so here, right, around health insurance. What happens to that? We currently have a like a code of conduct, like an optional code of conduct that the insurance industry kind of signs up to in the UK. I actually think it would be reassuring for everyone to turn that into primary legislation. I think that would just clarify, because if we're saying to people, take part in this program and your genome will be on file, not just today, not tomorrow, but for the rest of your life, they need to feel confident about the future. And so I think we need to give them, obviously, and we've had this in some of the many public dialogues that we've run. Yeah, we trust you guys, sure. We trust the government, yeah, we trust the NHS, yep, definitely. But what if in 20 years' time, there's some crazy government that does some crazy stuff with my kids' data? How can we do that, right? And you can never say, we can reassure 100% that nothing bad will ever happen. But what you can say is we're going to put really big barriers in the way to bad things happening. Primary legislation is one of those, around how we access this. The other big barrier that we've put in place in Genomics England, and I know at the Broad and other places, is a model where the researchers come to the data. We're not just putting all the data on encrypted hard drives and mailing it to researchers. And so I think the more of those kind of reassurances we can put in place, the better we can operate these collaborations, which are so essential to actually bring the right benefits to the right patients.
So I'm a big believer in academic, industry, and government partnerships. Again, sort of my personal experience in the prenatal world, the prenatal genomic screening would be nowhere without industry. But what we learned from that was in the marketing examples that I think that's where the guardrails have to be, because there were some critical errors made at the beginning of the availability of prenatal genomic sequencing, where it was implied that the screening tests were as good as having an amniocentesis or a CVS. So that led to people having possibly unnecessary terminations because they felt that their screening result was a diagnostic result. Now, part of that came from the fact that this was new, people were marketing the technology, and then there was competition between companies. My hope is that in this field, there's not quite the same issue because specific companies are working with specific conditions, and it's a little bit more altruistic, I would hope. But I do think that there are lessons to be learned about the marketing. I was reassured to hear, for example, that Don Bailey said he did a 180-degree turnaround, and that's essentially where I came from too originally, at Harvard was like, you shouldn't be working with industry, you can't publish, it's completely different now. So we're all evolving, and even at the NIH, we're evolving. We have the Accelerating Medicines Partnership. So there are lots more opportunities to partner between government-funded research and industry.
Fantastic. I'd like to let people start to consider questions that they'd like to ask. There are people with microphones, and we'll call on you. While you're thinking of your question, I got one more question. If we turn that around, and we're thinking not so much of industry, cautionary issues about industry, but cautionary issues around regulation. So in the United States, we have the FDA and NIH and CME and CMS, and we have similar organizations in the UK. We have voluntary organizations. Heidi, you're very active in Global Alliance for Genomic Health. Which, if any of these, are going to be appropriate guardrails? Which, if any of these, are going to be difficult or even obstructive? Which of these do we need to moderate to work to help us better than they are now? Very open question, but maybe Diane, starting with you.
So let me just clarify, the NIH doesn't make policies. What we do is we fund the research that generates the data that then informs the policymakers. So it's very clear what our role is. And I think evidence is in all of these studies that we funded, those data go into the data that are used for the RUSP to make decisions about what is going to be screened. And certainly those data are used by professional societies to make professional guidelines. So that's our role, that's our swim lane.
But may I stay with you for a second and ask, remember when the FDA took an interest in the INSIGHT studies? And this, from the investigator side, this was perceived very, very, very difficult challenge. And Heidi, by the same token, you've been interacting with the FDA quite a lot around the sequencing process as a device writ large, which is really counterintuitive. From sample collection to report generation is somehow a device. Sticking with the US for just a second with you two, where are we now? How is that whole process looking, both with the FDA and other federal organizations?
I think Heidi's going to know much more about that.
Yeah, I mean, we've obviously, for the All of Us research program, has come under an FDA IDE, and so we've had to work very, very closely with them. You know, I think some of my frustration is we do have a regulated laboratory system in the US, and there's a lot of oversight. We're all accredited. Most of us have CAP accreditation, some sort of, CLIA-based accreditation process, and that has to assess all of the safety concerns and validation of our tests and ensuring that they are validated appropriately, and we do proficiency testing and all of that. And I actually think that system works reasonably well. However, none of that is asking the question, should you do this test and how do you market it? That's really not the purview of CAP, as a accreditation organization. And so I would really want, some more approach to how do we really regulate the appropriate use of these technologies in what populations, and a little more way in there and less in the weeds at every variant that we use to validate our assay, because honestly, we do that pretty well. And I wish, there had been a slightly different focus on a lot of what we were doing. So I think there is space for more, and it's maybe less about regulation and more about a societal question about how to do this most appropriately and what populations are going to be served or underserved and what's ethical, and have some serious dialogue in our community about how to go about this the most thoughtfully and effective way. And I wish there was more on that end and less of me, writing a 400-page report on every variant I've used to validate an assay.
Chris, in the UK, I've heard a quote from one of the lions of screening in the UK that said something like this: all screening is harmful. Some screening will also be beneficial. And a real public health orientation that says whenever you screen, you're going to make mistakes, you're going to do unnecessary diagnosis, which is going to lead to unnecessary treatment. But in some cases, and hopefully most cases, there is a countervailing benefit that far and away exceeds that. So as you think about that approach and the strong traditions of public health in the UK, what are some of the stories you've had to, we'll be off the record here, except for the streaming to the world. What are some of the stories that you can tell us, or some of the challenges you faced or anticipate facing?
So it's a great quote. I think to the credit of the National Screening Committee in the UK, they're very forward-leaning on this. Like, they sit on our steering group. They're very, very positive about it. That's not least because we've had a huge number of kind of public dialogue sessions and so on to reassure ourselves and everyone else that we're not out on a limb here. I think Heidi's point about societal dialogue is really, really important. There was a fantastic process in the 1980s and early 90s led by a lady called Baroness Warnock, which was the Warnock Review around human embryology and fertility. At the time, the Catholic Church, the scientific community, the various different religious communities, et cetera, politics, all up in arms in various ways about this emerging science. What could we do with it? What was moral? What was not? Baroness Warnock led a sort of masterful process of engagement and dialogue and synthesis to get to a point where you had guidance that you could pin up on the wall of a lab that said, right, before 14 days, you can do A, B, C, D, E, F. After 14 days, you can do G, but nothing else. And beyond 28 days, you can do nothing at all. And maybe this is more multifaceted, but I think that the more we can get to concrete outcomes from these kinds of dialogues, as well as having the dialogues, which is a benefit in themselves, the more powerful that is. So David Bick, who's over there, who I'm sure everyone will be familiar with, has also been, as well as those kind of public dialogues, having hundreds and hundreds, literally, of clinician conversations to think about each of the genes and variants that are on our list and saying, right, what if this pings, right? What if this kid, if number 117 on the list pings, who do we call? Who are the leading clinical practitioners in the country who are going to have to take care of that kid? What are they going to do? How confident are they going to feel about the ping from this screening test? And it's part of it is just the shoe leather of kind of having those conversations, so that when either concerned activist groups, new parents, politicians, regulators say, "Well, hold on, have you guys really thought this through?" We can say, "Yes, we have, right?" And then there's the kind of accreditation pieces. We're also in we've left the EU, but we have basically equivalent regulation now around in vitro diagnostic devices, and that's quite a culture shift for people who've been working in genomics, right? Because it used to be in the lab, you could kind of do what you want. Your smart postdoc could build you a new pipeline, and you could just crack on, right? And now it's like, what do you mean we have to be ISO accredited like 17 different ways, and CE marked and blah blah blah? It's like, this is the price of success, right? It's like, if you want to go and build 100,000 homes, they better have robust steel bars, and the bath had better not fall through the ceiling. So as genomic medicine comes more and more into the mainstream, I think it's actually good that we have the right regulation, and it should be about steel beams and robust floors, not about where the sink has to be or what kind of tiles you have to have on the floor, to your point, right? We need to have the freedom to operate within that, but we need to be demonstrably operating responsibly and building robust systems as tens, hundreds of thousands of people come through these programs.
Great. Any questions from the audience for this group? Don't be shy. Brenda? Oh, we have one from the live stream. Great. And we have one from Chaka, but let's take the live stream first.
This is a question from someone watching via live stream. They want to know if the panel has any thoughts on how to address the challenge of this is their word, not mine, crumbling public health infrastructure in the United States, given the important role that state departments of health have played in traditional newborn screening programs and also long and short-term follow-up.
It's a great question. I was going to mention that I think that COVID-19 has taught us a lot about not only the public health infrastructure and the need to shore that up, but also developing trust. We spent a lot of time at the NIH, particularly with testing, working with communities to establish trusting relationships, which are not built overnight. So it's a massive problem, and it's an understaffed, underfunded problem. And so now state labs are struggling to do what they do currently, and we're asking them to do more. I don't have the answers, but I hope that attention will be paid to the need to shore up the public health infrastructure. But I believe everyone in the room here is an advocate for public health. That's not true if we walk outside onto the streets of Boston. I don't think everybody's going to agree with us.
Yeah, I mean, we've obviously worked very closely with the State Department of Public Health in the COVID crisis for the last 2 years doing COVID testing. And actually, I've been quite impressed by Massachusetts Department of Public Health in terms of a lot of work done during that era. Are they, perfect? Are they fully, staffed sufficiently? No, but I would argue that's true of our healthcare system equally as much. So I don't know that there's any one sector here that's more poorly resourced than the next. I think we have a lot to shore up in all sectors, but I think we all just have to work together.
I mean, I think we had COVID in the UK too, right? We have a really overstretched healthcare system in the UK too. I think a lot of these problems are kind of global. I mean, we spend 9% or so of GDP on healthcare. You guys spend about 18, 19. I don't know what the exact number is. So there's a lot of money sloshing around, I think all of us are thinking through how we bring these kind of cutting edge technologies into a context of professional communities who are just frazzled and exhausted and overstretched and even delivering what they see as like the core of their mission into technology systems which are often heterogeneous, often many years or decades old. The COVID thing is interesting. One of the follow-up points in the UK about COVID is we have huge lab infrastructure that we never had before. So one of the things we're thinking through as we think about these kind of programs is there a way of tapping into and sustaining some of that massive increase in lab infrastructure were we to want to commission this as a live service, do this as an ongoing thing? But it's an interesting question, and people are also people. There's no such thing as people, right? Like lots of different communities, lots of different individuals are much more intellectually engaged with the concept of a genome, right? Pathogen screening and so on. We're testing ourselves at home. We know what PCR tests. All of these things have really radically shifted in the last couple of years, and so I do think that creates opportunities for these kind of programs to take root in a kind of trustful and productive way, as well as a load of challenges.
We've got about 5 minutes left. Shaka, you wanted to make a comment or a question? And then I've got one last question to ask the panel.
I'll make a comment first. First of all, I want to thank everybody who put this meeting on, because I think you've done a tremendous job of, at least, and of one, I'm a believer, right? Everyone should have their baby sequence, right? And I think it should be a movement. And as I heard some of the facts about rare disease and infant mortality, et cetera, why wouldn't we, right? One of my questions, following up on that statement to the panel, is what do you think is the biggest barrier to this actually becoming a movement, making it something that every child gets done? And how would you overcome that barrier for each one?
Actually, that's a perfect piggyback to my final question to them, which is what, in addition to Shaka's question, what do you think is the greatest barrier to moving this into, I think, universal practice?
Yeah.
What advice would you give to the assembled PIs here? Still in the room are most of the people in the world who are doing the earliest studies on this. So what are the greatest barriers that you see, and what advice would you give the PIs assembled here in the room?
I mean, I can start. I think the biggest barrier in my mind is that to effectively interpret the variation we find in anyone, let alone newborns, we need a good evidence-based, and that's what's pathogenic, and if pathogenic, what is the risk of developing a disease, and with whatever disease, what's the phenotype, what's the penetrance, the expressivity, is this a hypomorph or is this a, fully fledged null allele? The only way we're going to really learn that and overcome that is to share widely the evidence base. And that's going to both enable us to actually give back accurate and predictive and useful information to both newborns and anyone else who gets genomic information. And it's also going to allow us to scale because we'll actually have the evidence at our fingertips. We won't be spending hours reading papers in the literature and calling up our friends saying, you submitted this to ClinVar. Can you tell me what patient you saw it in and what their phenotype was? And then you send by email. It's not going to scale. So I think that to me is our biggest barrier, is that evidence base.
Should we do that under GA for GH auspices, Heidi?
Well, the standards to do that would absolutely be informed by G4GH, but the actual implementation of it, has to be all of us in our respective institutions because we control the data we collect, the patients we serve, et cetera.
Yeah, so I would say I certainly agree with Heidi about interpretation and variance, but I think education is a huge barrier, not only of patients or participants, but primary care providers, wherever they are on the healthcare scene. And this is such a chronic problem. There's so few hours in the medical school curriculum devoted to genetics and genomics, and genetics and genomics is moving so quickly, it outpaces any education that you had when you were in training. So how do you make the provider comfortable? I heard today people talking about you need to give information to the physician so that the physician will feel comfortable explaining to the patient. That shouldn't be. We should have a system where the provider understands what the tests mean and can communicate it. So I still think that's a huge barrier because we're never going to have enough geneticists or genetic counselors. We have to integrate that into the larger healthcare system. As far as advice for PIs, I would agree with data sharing. I mean, the NIH is going to require that as of, I think, January 23rd, any NIH application is going to have to include a rigorous plan for data sharing. And so I know people are going to be grumbling about that, but it's going to pay off in the long run, that we will be able to tap into these larger resources. And this is an area as well where we learned a lot from COVID-19 and some of the major projects that were funded during the pandemic. So data sharing for the PIs. You don't own your data.
Chris, final thoughts, biggest obstacle and advice to PIs.
I think we've talked about a lot of the obstacles, right? And I think there are a ton of pragmatic ones. The evidence base for the genomics itself, the evidence base for this being a useful thing to do at a healthcare system-wide scale, issues of trust, data sharing, very pragmatic things like, should we resequence in 10 years or should we pay this cloud storage costs for 10 years? There's all of these things, right? But and for this phrase, all of us now has a totally different meaning as well. Right? For everyone involved in this conversation, I think there is a really important point here about painting a vision of where we want this to go, right? Because if we focus on those obstacles, if we focus on those barriers, we can beaver away for 20 years working on them, but we still want to brought the communities that we serve along with us. I love Shaka's point. I think both about thank you to everyone who's convened these sessions, but also about a movement. And if we think about something like Asilomar, if we think about other kind of really important meetings in the history of genomics and science, what would it take for this meeting to be like one of those meetings, right? How can we follow this up with what we're learning together, the principles that we want to adopt as a movement, the benefits that we can see emerging for patients? The way that we pitched this to Treasury to get the funding for newborns was partly using a kind of slightly facile analogy from me, right? I listen to a lot of music on Spotify, and every week the Spotify Discover weekly playlist arrives in my life, and it's full of these songs I've never heard before that I really like. I'm like, wow, how does it keep doing this, right? It does this because I'm sharing my data with Spotify. It's using clever algorithms to come up with recommendations, right? And I trust Spotify to process that data, securely. I'm deeply embarrassed about some of the music I love. I don't want the world to know, right? What I dance to in the shower. But there's a much grander kind of opportunity here, right? If we can build that trust where people feel comfortable sharing their data with health systems, with the NHS, with Genomics England, with the kinds of organizations we have in this room, if we can start making recommendations right from the moment of birth all the way through someone's life about not just what music they might like, but how they can optimize their wellness, how they can extend their healthy years of life, where they maybe want to get an early checkup on a particular condition. That's incredible, right? And in the UK context, congratulations, as a citizen of the UK, you get a free lifelong subscription to this service. For a health system in the UK, like United, like Kaiser, like Geisinger, like whoever, it seems to me there's an incredible sales pitch to be had there to kind of bring more patients into your system, right? And so I think if we can paint that vision of where we think this can take us, and if we as a community can be articulate about why this is a good journey and why we're listening and trying to do this in a trustworthy way, I think the future is very bright.